So with that, I would like to invite Dr. Rohan. He is professor at RP Center. He needs no introduction, and he being a chief instructor would be talking on the posterior pole retinitis. He has very nice way of classifying and identifying posterior pole retinitis. Let's hear to him.
Hello. Yeah. Thank you, Dr. Vinod. So we have now seen some large areas of retinitis which have been explained, which have been categorized into ARN or CMV. So sometimes we see smaller patches, and sometimes some of these are concentrated on the posterior pole. Shaurya touched on a bit of them. So I would like to just again touch on these patients who have these white patches at the posterior pole, which we call as posterior focal retinitis, and how would you on a clinical examination try to differentiate and empirically decide what category this falls into, what empirical therapy should I start before, if at all, I want to do a further PCR or an serology which might confirm the diagnosis. So what I'm going to talk about is we have had a lot of publications on this. So, like I said, it can have multiple etiologies. It could be viral, it could be bacterial, it could be toxoplasma. It could even be non-infective, though although rare. But since they are at the posterior pole, they are vision threatening, and one needs to start this empirical therapy before we can get confirmation from some of the laboratory investigation. So you see one lesion right here, you see another lesion here, and the third lesion here. So all three of these had signs of inflammation in the eye, so we were thinking on lines of retinitis, but they don't look alike. So are they the same organism, or by the look can we tell something about what is causing this retinitis? So the first one was very typical, again same photograph with Dr. Shaurya. You see this focal retinitis. Rarely would you see some hemorrhages. In this patient there is a sort of hemorrhage, but sometimes few hemorrhages can be there. But again the very typical same thing, if there is adjacent scar, if there is a vitritis, it's a fluffy sort of white lesion. So that fluffiness in that nature is over there. Disc edema may or may not be there, but sometimes the exudation may be significant. You can also have an exudative RD associated. And again in the OCT you would see the full thickness involvement of the retina progressing towards the choroid. And now some people in toxo also have described, if you see this detached layer of hyaloid. So under this detached layer of hyaloid, the pointer is not coming. Can you give me a pointer? So under that detached layer of hyaloid, focal thickening, if there is, are seen with retinitis, people have ascribed it to toxoplasma again. Okay, so under this hyaloid, if you see these focal areas of thickening, so that again sometimes with this white area, people have talked about as toxoplasma. So as discussed, in all these infective retinitis, withhold your steroids at day 1. At day 1, please start whatever antiviral or anti-infective therapy you are planning to give. So start the sulfamethoxam, trimethoprim, wait for 48 to 72 hours, and then start steroids. That will be more helpful, as we have learned from COVID. Day 1, if you are starting in the stage of the multiplication of the microorganism, then that is harmful. So let the stage of multiplication die out a little bit with your anti-infective therapy, then add the steroids to help the inflammatory component. And the alternative therapy, nowadays people are also giving intravitreal clindamycin, which can be given once a week in some of the very posterior pole sort of lesions. So again this same sort of patient, you start getting this clearing once you start getting more of this necrosis. So only this ILM sort of draping here, full thickness retinitis. And again you see, since it is going to the choroid, this choroid hump is also now started developing over there. Another one, the focal type of lesion without much vitritis, but again because it's initially retinitis, we treated on basis of toxo itself. Now this patient here, when I saw this lesion, it may be not so much clear here, but I thought it's a very deeper lesion. I thought it's probably a choroiditis rather than a retinitis, but the patient had only minimal symptoms. The patient did not look very, looked a little sick. So the only investigations, and then I did a OCT scan through this, and the OCT told me no, it's not a primary choroiditis by the fuzzy margins, whatever the wrong look impression I was getting, it is rather a retinitis. So a retinitis with not a very healthy looking patient. I just did 2 investigations, and the patient came out to be HIV positive and toxo IgG positive. We treated with anti-toxotherapy, and now you see you've got that scar over here, full thickness scar. Okay, so the second is a viral retinitis. This I have sort of seen, these are white stuck on plaque like lesions, unlike the fluffy lesion which I showed you earlier. and these progress faster, causing schisis. And these also, once the schisis is occurring, the vessels in the inner retinal layers start getting disrupted, and so you start getting these hemorrhages. And some of these patients might give you some other symptoms. Like one young patient I saw while we were doing the imaging, threw a fit in the clinic itself, had a convulsion, and we then did an MRI, and they had a temporal lobe lesion. So some of them can have these systemic features as well. So this was a young girl. We were initially thinking on a vascular occlusion sort of thing, but there were signs of inflammation. You can see even on the OCT, just below the highlight, you can see these cells over there. And so this patient was initially given IV steroids outside, worsened significantly, but we could see it's flared up slowly under our visualization, developed break, developed a detachment. This eye was lost, but since we had started antivirals, perhaps we could preserve the other eye, although a lot of thinning, but we could preserve at least 6/60 in the other eye. So this is the another young boy. See, this is more of a plaque. This is not that fluffy nature in that, and these hemorrhages there, and you can see this thinning, necrosis, schisis all developing in the OCT. This is another young patient with that plaque. I again thought it is herpes, but on detailed neurological examination and even a biopsy from the brain revealed something else. It revealed a simian virus. Now talking of what I've talked about, if you see this lesion, what would you say? Would you call this fluffy white with some hemorrhages? Would you call this toxo, or would you call it viral? So then nothing in medicine is sacrosanct. You take history. This patient gave history of immunocompromised status, and this on actually aqueous PCR came out to be CMV. So you can always have some exceptions. So so this patient was treated with CMV therapy. So initially it worsened. We were a little scared, but slowly it settled down, and the patient also again had 624. So this is the third type, which mimics sometimes like hypertensive retinopathy, but again signs of inflammation on clinical as well as OCT. You see a neurosensory detachment, you see white focal thickened areas. Now this is something called a post-fever retinitis. Etiologies can be multiple. It can range from rickettsia, Lyme's disease, to West Nile virus, to many other things. So, but these patients I like to treat empirically with doxycycline, because at least some of these bacteria do respond, and they respond very well. Some cases I have seen we did not even have to add steroids. But yes, start doxycycline initially. So this can be due to various etiologies. Start doxycycline, and if at all the NSD is not settling, the edema is not settling by about 3-4 days, then you can add on your steroids and continue the doxycycline for about a month, and slowly you can taper off the steroids. Very rarely, with some cases where the edema I had seen was about 1000 microns or 800 microns, I have even injected Avastin just for a quick response. But the main therapy would remain Avastin, doxycycline. And just to show you some cases after therapy, some of them have shown a very nice resolution, and many of them have recovered even 6/12, 6/9 vision. See, very nice resolution is seen. Slowly those hard exudates and all also would go away. So we had done an analysis of these cases with serology also. Now I've stopped doing serology because probably my therapy doesn't change by that. But if you are doing a study or something, good idea to do. Some of them will come out positive for rickettsia and Lyme's disease. So now just to again leave you with this case, what do you think would this patient, this lesion would be? Would it be toxo? Would it be post-fever? Would it be herpetic? Or would it be CMV? CMV. Okay, so again, history taking has to be there. You have to see the patient in total. This patient was carrying a record of hypopyon and uveitis recorded. So this patient is diffusely leaking everywhere. It was more of a Behçet's focal retinitis. In this patient, we just treated with oral steroids. Okay, so that also can be, should be in the back of your mind. So the broad categories, first I would say toxoplasma, everyone should know what it is. Second, there is a flat plaque-like lesion, it could be viral. Third, if it is a history of fever is there, history of rash is there, or you are seeing something like multiple cotton wool spots with inflammation in the eye, it comes in this category. Or rarely, yes, do not miss out the other histories of oral ulcers or some other signs like a hypopyon uveitis. It could be Behçet's disease. But whatever it is, when you think it is retinitis, please avoid initiating therapy with steroids. Start one of the anti-infectives first, and then after a few days go on to add steroids. Thank you. Thank you so much.
Thank you, sir. I think one general rule which we all can follow is that by and large all retinitis are infective predominantly. On the other hand, all choroiditis are usually non-infective. So that is a general dictum. It is not always applicable, but once you think of retinitis, please rule out infectious agents and then think of adding steroids and vice versa. So, are there any questions?